السلام عليكم. Hello everyone. Dr. Tariq, I
نعم.
sent the scenario to the group. We'll give you
Yes.
2 minutes to prepare and then we will start, okay? Tell me when you are ready.
Okay, sir. Okay.
Are you ready, Dr. Tariq?
Yes, sir.
Okay, start.
Hello, good evening.
Good evening, doctor.
I am Dr. Fresat, one of the doctors in the joint clinic.
Welcome, doctor.
May I confirm that I'm speaking to Mr. William, 32-year-old?
Yes, doctor.
Okay, Mr. William, we are here today to discuss some issue related to your health. Is that okay with you?
Yeah, sure, doctor.
Okay. I received a DB letter telling me that you have been skin rash. Can you tell me more about that?
Yeah, doctor, this rash is actually there for a long time before, since childhood. I am not here for the rash. I'm here actually because of my blood pressure. Recently, I went to my GP. He checked my blood pressure, and it was found to be high. So he advised me to come to your clinic for advice and possibly treatment.
Okay, I'm sorry for that, Mr. William. When did you notice that your blood pressure is raised?
Just recently, doctor. He did several readings, and all of them were high. Have a look on the screen. This is the skin rash, if you are able to see it.
Okay. Mr. William, do you have any headaches at all?
No, doctor.
Any nosebleed?
No.
Any blaring of vision?
No.
Okay. Is there any past medical history of note that I should be aware of?
Not to my knowledge, doctor.
Any past surgical history before?
No, never.
Any family history of note, Mr. William?
Just the same rash, doctor, if you can see. The same rash. My brother also had the same rash, and my father also.
Any problem in your hearing, Mr. William?
No.
Any history of fits at all?
No.
Okay. Any change in your water work?
No, doctor. It's fine.
Okay. Do you have any joint pain at all, Mr. William?
Joint pain? No, doctor, but I have got back pain.
Okay. Since when you have this pain?
Back pain is actually not that severe, doctor, but it's on and off for a long time. I'm not sure, really.
Is it increasing by rest or movement, Mr. William?
I don't think it's related. Sometimes it increases movement.
With movement. Any history of trauma before?
No trauma.
Okay. Do you have any skin rash apart from this, Mr. William?
Yes, doctor, here also, as you can see in my finger, and also near to my upper lip, if you can see the picture.
Yes.
I have got these lumps, doctor. One of them is really painful. It is down here in my hand, if you can see it in front of my wrist.
Yes.
Yeah.
Any problem in your sensation, any tingling, any needles?
No, doctor, I do not have any tingling or needles.
Okay. What did you do for a living, Mr. William?
I used to work in the local supermarket, doctor.
So how these symptoms affect your job and daily living activity?
Not really, doctor, but sometimes the way I look is really important.
Hello. Hello, Dr. Hussam. Hello. Hello.
Sorry, I had a connection problem, Dr. Tariq. Continue, please.
Yes.
Just let me start the timer again.
Yes.
Yeah, continue.
I was asking about the job.
What exactly?
I was asking about the job.
Job, yeah, doctor. I work at the local supermarket. I am coping well, but really embarrassed by this rash, doctor.
Okay. So, is there any history of recent medications you have used, Mr. William?
No.
Did you receive any recent analgesics, painkillers?
No, at all.
Do you smoke?
No, I do not smoke, doctor.
Okay. Can I examine you, Mr. William?
Sure, doctor.
Okay.
2 minutes. 2 minutes remaining. Okay, what do you want to look for?
I would like to look for the rash.
Yes, there is coffee ole spot, as we just
Yes,
showed.
cafe ole spots and neurofibromas. I will measure the blood pressure. And
blood pressure is mentioned outside.
Okay, and see if there is an axillary freckling.
Axillary frecklings?
Yes.
Just a moment. I will share a picture. Okay, this is his axilla. Can you share it?
Yes, I would like to listen for if there is renal artery blowy at all.
Positive.
Okay. What is your concern, Mr. William?
Yes, doctor. What is the cause of my high blood pressure, and any way to help with my appearance? I mean, this rash.
Okay. I appreciate your concern, Mr. William. Actually, from what you have said to me, and after I examined you, you are most likely have a condition called a neurofibromatosis, which is a familial disease. I mean, run in families. Leading to this skin rash and high blood pressure is related to a condition possibly called pheochromocytoma. What we are going to do now is to refer you to the multidisciplinary team, including gland doctor and internist, and the skin doctor to take care of this skin rash. We will run for you some blood tests to confirm the cause of your high blood pressure, this pheochromocytoma. And if this pheochromocytoma is present in you, we have to refer you to the genetic counselor. As I told you, it is a familial disease, and there is a syndrome calling MIN2 syndrome, which is composed of pheochromocytoma and this neurofibromatosis. Any further concerns, Mr. William?
No, thank you, doctor. Seems okay. So will you need to admit me to hospital?
No need for admission to hospital. No.
Okay, doctor, thank you.
Thank you.
So I think I have got few seconds left. Oh, time up already. Okay, so doctor, what is your diagnosis?
Actually, Mr. William presented with high blood pressure and skin rash with a positive family history. On examination, there is cafe olet spots, axillary freckling, and neurofibromas.
Okay.
Most likely, he had neurofibromatosis type 1, since there is no hearing loss in the history, with the association of pheochromocytoma.
Okay, what in the history or examination suggests the possibility of pheochromocytoma?
Nothing except the high blood pressure, which is a common association with the neurofibromatosis.
Okay, what is the differential of high blood pressure in patients with neurofibromatosis type 1 you are aware of?
At first, I will consider this pheochromocytoma, renal artery stenosis. Any recent unsaid use could induce high blood pressure.
So, what else? You detected a finding, I think, renal bruit. Could this be related to high blood pressure in patients with neurofibromatosis type 1?
Yes, it could be renal artery stenosis. If the patient is female, I could consider fibromuscular dysplasia.
And in this particular patient who is a male, any other possibility apart from apart from fibromuscular dysplasia? I mean,
renal artery stenosis.
Okay, time up. Okay, Dr. Tariq, you did very well. Although you got somehow you got confused at the end of the station. I don't know why, but you started very nicely at the start. So despite you did well, but still, as usual, I have got some comments because we are aiming for the full mark. Okay, so these comments are not necessarily regarding your performance, but also for the benefits of others. Okay, so you started by telling the patient, I would like to discuss some issues related to your health. Okay, it's better in session 5 to tell him that I would like to ask you a few questions regarding your health, and then I may need to examine you at the same time, if that's okay, because you will take history and you may need to do examination at the same time. Okay, so you started very well, but if you attended the previous sessions in session 5, we told that the open question should be wide open. Okay, sometimes they will give you some complaint from outside. When you enter the station, the patient will have another concern. Okay, will have another main presenting complaint. So this patient from outside, they have written rash. When you enter the station, the patient will tell you, no, actually, doctor, this rash is present since childhood. I'm not concerned about the rash at all. My problem now is I went to my GP. He found that I have high blood pressure and he sent me to your clinic for further advice. So always in session 5, try to keep the question wide open. Can you tell me what brought you into clinic today? And let the patient elaborate for you. Okay, tell you what is his main concern, what is his main problem. Okay, because his main problem does not necessarily the same written outside. We know that it is written rash from outside, but when you enter the station, keep your open question wide open. Okay, so you did well in asking about symptoms of hypertension. Okay, that was very nice. Okay, then as soon as you enter the station, most of the station 5 cases, you will find some striking abnormality, which will lead you to a diagnosis. Okay, if you enter a station and you find a patient with neurofibromatosis, it will be very obvious. So do not take a lot of time asking about hypertension, the complaint which might be related to hypertension, and complications related to hypertension. Instead, try to catch your diagnosis, because there is a lot of things to cover here. You need to search for the cause. You need to search for the clinical presentation to confirm the diagnosis. You need to search for the complications and associations. You need to manage the patient concerns, and there may be a lot of concerns, and you need to explain the management plan. So as soon as you catch your diagnosis, don't go here and there and here and there. No, directly go to the complaint, which will give you the diagnosis. Okay. Regarding your rash, Mr. William, can I see it? The first question for the rash should be, can I see it? Okay, because imagine this patient has got a rash of eczema, for instance. It will be itchy. Okay, imagine he has got a rash of psoriasis. It will be scaly. Okay, imagine he has got a rash of vitiligo. It might not be painful or itchy or anything. If he has a rash of pityriasis versicolor, it will be itchy. So the symptoms which you will ask about depends on the rash. So you have to see the rash at first. For how long has it been going over? Let me see the rash. Okay, as soon as you see the rash, you will find that this is pathognomonic coffee ole spot. Okay, and coffee ole spot usually has got few differentials. And taking in mind that this patient has got high blood pressure from outside, this is definitely neurofibromatosis. Okay, especially that he has got another neurofibromas, okay, in his lips, in his hand, and he has got also plexiform neuromas. So I will just share my screen again to show you these rashes. Okay, so are you able to see the photo on the screen now?
Yes, yes.
Okay, so coffee ole spot, it will be like brown to coffee colored patches of skin. It will not be elevated above the skin surface. Okay, it has got few differentials like neurofibromatosis and tuberous sclerosis, mainly PACES-wise. These two differential, either neurofibromatosis or tuberous sclerosis. Okay, other findings are neurofibromas. If you can see here, this pump or elevated lesion. Okay, this is a neurofibroma. Coffee ole spot, in order to confirm the diagnosis, you have to find at least 6. Some textbook mention 5, but almost most of the textbook mention 6 coffee ole spot, which has to be at least 15 millimeter in diameter. Okay, so 6 coffee ole spot, at least 15 millimeter in diameter. Okay, then you should have at least 2 neurofibromas, like this one on the screen. Neurofibromas is a benign growth of the nerve endings. Benign growth of the nerve endings. Usually, it is harmless. It will not turn into cancer. Okay, it will not cause symptoms. Sometimes, only for cosmetic reasons, it might be removed by laser therapy or surgery or so on. Okay, so at least 2 neurofibromas. Okay, and these 2 neurofibromas, one of them has to be plexiform neuroma. Plexiform neuroma. This one is a normal neurofibroma. This one also is a normal neurofibroma. You are able to see my screen, right?
Yes, sir.
Okay, so this is neurofibroma. This is another neurofibroma. How to know that this neurofibroma is plexiform neuroma or plexiform neurofibroma? You will ask the patient, is it painful or tender or itchy? Okay, if it is painful or tender, especially after trauma, this is plexiform neuroma. Okay. Then the other different plexiform neuroma usually is larger inside, as you can see this one. Are you able to see in the screen?
Yes.
This one is a little bit larger compared to this one, right? And this one also, if you see the border, it is diffuse border, not like this one, the normal neurofibroma. Okay, the normal neurofibroma will not be painful or itchy. The plexiform neuroma will be larger, diffuse border, sometimes itchy, sometimes painful, especially if the patient sustained any trauma. Okay, histologically, the neurofibroma, the normal one, it will be from single nerve, okay, or part of the nerve. But the plexiform neuroma usually involves the entire nerve, whole nerve, and sometimes even collection of nerves in one area. So it might affect multiple nerves in one area. Okay. Did you get the point? So
Yes.
at least 6 Cafe au lait spot. Each one should be at least 15 millimeter in diameter. Okay. At least 2 neurofibroma. One of them should be plexiform neuroma. Okay. Then axillary fricklings. Sometimes people are confused about axillary fricklings. They think it is like wrinkling or something, like xanthoma elasticum. No. Axillary frickling is just simply small round areas of hyperpigmentation due to melanin deposition. If you can see in the screen, is it clear? So just
Clear,
multiple small round dots which is hyperpigmented due to melanin deposition. Okay, this is one of the criteria also. Then other criteria include Lish nodules. Lish nodules, it's a benign, small, tiny growth in the iris. Okay, usually it is only 1 to 2 millimeter in diameter. It's very small. Okay, ideally you should be examining for Lish nodules using the slit lamp, but sometimes it can be seen even by the naked eye. Only with the torch you can see Lish nodules. But eventually you have to refer the patient for slit lamp examination in order to differentiate between Lish nodules and another similar lesion in the iris, which is iris nevi. Sometimes they will be iris nevi. It will be similar to Lish nodules. The difference is that Lish nodules is usually elevated from the top of the iris, dome shape. If you can see, it is not flat, like just changing color. No, it's a dome-shaped lesion, sometimes oval, sometimes round. Okay, it will be brown or coffee color. Okay, ideally it should be examined by a slit lamp, but you can check for that in the exam with a torch. If the examiner asks you, you will tell him that ideally it should be examined by a slit lamp, but sometimes it can be seen by the naked eye. So just to recap again, coffee au lait spot at least 15 millimeters in diameter, then axillary fricklings, then 2 neurofibromas. One of them should be plexiform neuromas, then Lish nodules, then add in our case family degree, first family degree with neurofibromatosis type 1. Okay. And here, and so on, the diagnosis is confirmed. Okay, so after you examine for the rash, neurofibroma, axillary flicking, Lish nodules, okay, you ask about the family history. By this time, you confirmed the diagnosis of neurofibromatosis. Okay, we have mentioned previously in station 5, in order to get the full mark, you have 4 points to cover, 4 major points to cover. You have to know the cause of the disease. Okay, here the cause is autosomal dominant condition. Okay, autosomal dominant condition, and this is supported by positive family history. Okay, then the second C is the clinical presentation. And we have mentioned the criteria to diagnose neurofibromatosis. The findings we have mentioned, at least 2 findings positive, then the diagnosis is done. Okay. Then the third C is complication. This patient, from outside, they gave you high blood pressure. Whenever you find in the scenario from outside, patient who is presented with rash and high blood pressure, you have to think about neurofibromatosis. You have to think about neurofibromatosis. So what is the differential diagnosis of high blood pressure in patients with neurofibromatosis? In this patient, you told me I would like to check for renal bruit. I was very happy. about this question, and I told you it is positive. But despite that, you did not mention to the patient or to the examiner that the high blood pressure might be related to renal artery stenosis. And by the way, renal artery stenosis is not necessarily due to fibromuscular dysplasia. It can happen in neurofibromatosis as a result of any neurofibroma, okay, occurring over the kidney or near the renal artery. You got the point? So it is possible to have renal artery stenosis in males, okay, with neurofibromatosis type 1. So the first differential, as in our case, is renal artery stenosis. The second differential, as you have mentioned, is pheochromocytoma. But in order to diagnose pheochromocytoma, you have to find symptoms like heart racing, panic attacks, blushing, okay? Not only high blood pressure. High blood pressure could be related to renal artery stenosis, could be related to essential hypertension, could be related to coarctation of the aorta. And this is our fourth differential. So differential diagnosis for high blood pressure in patients with neurofibromatosis type 1. It could be essential hypertension. So you have to ask about family history of hypertension. Okay. The second diagnosis is renal artery stenosis. So you have to check for renal bruit, okay, over the kidneys. At least mention this to the examiner. I would like to check for renal bruit. Sometimes he will tell you no need, skip, okay, or he will tell you it is positive, or he will tell you examine. But you have to mention this, okay, especially if you have given high blood pressure from outside. Okay, so essential hypertension, renal artery stenosis. The third differential is coarctation of the aorta, and there is association between neurofibromatosis type 1 and coarctation of the aorta. And coarctation of the aorta can give high blood pressure. So you need to check for radiofemoral delay. It is really important to check for radiofemoral delay, okay? And you can examine also by auscultating the back in between the scapula for the murmur of coarctation of the aorta. If you do not detect a murmur between the scapulae, this means that the coarctation might be abdominal, in the abdominal aorta. So you need to mention to the examiner that I would like to check if there is any difference between the blood pressure in the arms and leg. Okay, so just to recap again: essential hypertension, renal artery stenosis, okay, pheochromocytoma, and coarctation of the aorta. These are the differential diagnosis for hypertension in patients with neurofibromatosis. One more thing: this patient has told you that I've got mild back pain, which comes and goes every now and then, doctor. So, what could be the differential diagnosis for back pain in patients with neurofibromatosis type 1? Any idea, Dr. Tariq?
Sir, it could be fibroma compressing the spinal cord, maybe.
Excellent, excellent. What is the name of this fibroma? Spinal neurofibroma. Spinal neurofibroma. So now we have got three types of neurofibromas. Neurofibromas, which is cutaneous neurofibroma. Okay. Then plexiform neurofibroma or plexiform neuroma, which is painful and larger. Okay. Then spinal neurofibroma. This spinal neurofibroma can cause back pain in patients with neurofibromatosis type 1. What else? Any other differential? There is association between neurofibromatosis type 1 and scoliosis and kyphoscoliosis. Scoliosis and kyphoscoliosis both can give back pain. Okay. There is association with also osteopenia and osteoporosis. Osteopenia and osteoporosis per se can cause back pain, and they can result in compression fractures of the spine, which again will give you back pain. So you need to examine the back for any deformity, scoliosis, kyphoscoliosis, any tender spot which might be related to compression fracture as a result of osteoporosis. Okay, so spinal neurofibroma, scoliosis or kyphoscoliosis, osteoporosis or osteopenia. Other differential include any other osseous lesion, okay, or dural ectasia, ballooning of the dura, okay, will cause back pain, okay, and also coarctation of the aorta per se might cause back pain, by the way. So just to recap again: scoliosis, kyphoscoliosis, osteoporosis, and osteopenia, compression fracture due to osteoporosis, coarctation of the aorta, dural ectasia, osseous lesion, spinal neurofibroma, okay. And by the way, there is association between neurofibromatosis type 1 and vitamin D deficiency for unknown reason. Okay, people with neurofibromatosis type 1 will have vitamin D deficiency. I don't know actually whether this is related to the coffee or ole spot and the hyperpigmentation preventing the skin to get into contact, preventing the sun to get into direct contact with the skin or no. But anyway, there is association. Okay, so the back pain again can be as a result of vitamin D deficiency. Okay, did you get that? Shall I repeat, yes, or is it clear?
No, clear.
Okay, okay. So you mentioned to the patient that he has got neurofibromatosis type 1, and this is correct. But you mistaken the hypertension to be due to pheochromocytoma when there is nothing to suggest pheochromocytoma in the history. Okay, instead you detected renal bruise suggestive of renal artery stenosis, and this is the most likely diagnosis for high blood pressure. You ignored the back pain. You did not give the patient painkiller, which will result in some marks deducted from your clinical judgment. Whenever, we have mentioned this before, whenever you face a patient in station 5, you have got some points to cover. The 4 C's, which already we discussed: clinical presentation, cause, complication, association. And the other thing is the Abbas driving. We mentioned this before, right? A, admission. Does this patient need admission or referral? This patient will need referral, maybe to a dermatologist for cosmetic treatment for the rash. This was one of his concerns. And you did well in managing this concern. You managed to the patient that we will refer you for the skin doctor to get you treatment. They can remove it. They can do laser surgery for the neurofibromas or remove it surgically. Okay. And regarding the coffee ole spot, sometimes, despite it start in childhood, increase with age, but sometimes it fades away during adulthood. Okay. So the first A is admission. He will not need admission. He will need a referral. Okay. The second is P, which is pain control. He mentioned back pain. You have to tell him that I will prescribe you some painkillers to help with the back pain. Okay. Then alcohol and smoking, usually in such complicated cases, it will be negative because they have to he's drinking alcohol or smoking. The case will be a little bit lengthy to the point, so usually it will be negative. Then driving also does not apply in this case. There is nothing to stop driving in this case. So any question regarding this case? Any question? Is it clear so far?
So, doctor, regarding the skin rash, should I analyze the rash? Whether is it painful, itchy?
Usually, you do not expect coffee ole spot to cause any symptoms. It is not painful. It is not itchy. It will not cause any symptoms. Only maybe psychological impact. It will be like embarrassing for the patient. Okay, but usually, as soon as you find the coffee ole spot, you do not need to do anything. You don't need to ask about any symptom. Just try to count them, okay, and check the diameter.
Yes.
Okay.
So
you do not expect to. Yeah, exactly. It has to be at least 15 millimeter in diameter, and you have to find at least 6 in order to meet the criteria for the diagnosis.
So, doctor, in this case, shouldn't we have to screen for pheochromocytoma in order to rule out the mentioned one?
Sorry, mute all of you, please. Mute. Wait, I will mute all. So yeah, Dr. Tariq, you have confused neurofibromatosis with pheochromocytoma and multiple endocrine neoplasia type 2. The good thing is that the next case, it will be regarding multiple endocrine neoplasia type 2. I don't know, by luck, the next case it will be about multiple endocrine neoplasia type 2, and I will explain everything regarding multiple endocrine neoplasia type 2. But pheochromocytoma in neurofibromatosis type 2, is not related to multiple endocrine neoplasia at all. It is just an association between neurofibromatosis type 1 and pheochromocytoma. Okay. In multiple endocrine neoplasia type 2, you'll find hyperparathyroidism, you will find medullary thyroid cancer. Okay, but no neurofibromatosis there. Okay. There is nothing here in the case to suggest multiple endocrine neoplasia. Did you get that?
Yes, doctor. But in cases of neurofibroma, I know that we should screen for a pheochromocytoma, as it is a treatable cause for hypertension.
In case of pheochromocytoma, yes, you have to screen for multiple endocrine neoplasia type 2, but nothing in this case suggests pheochromocytoma. Nothing.
Yes.
Just the high blood pressure, which is related to renal artery stenosis. Got the point?
Yes.
Yeah.
Yes, yes.
Just to recap the criteria for diagnosis, we mentioned TFO spot. Okay. We mentioned neurofibromatosis. At least one of them should be plexiform. Okay. We mentioned also the Lisch nodules. We mentioned family history and axillary frequencies. Just one more point I would like to add is the optic gliomas. Optic gliomas, benign hamartomas of the optic nerve. Okay. This usually will not cause problem, but if it did cause a problem, it might result into proptosis, okay, or reduced visual acuity. Proptosis or reduced visual acuity. But usually it is just an incidental finding on imaging. Okay, if the patient did MRI for any other reason, you might find optic glioma. Okay, but usually asymptomatic. If it did cause symptoms, it will either cause reduced visual acuity or proptosis. Okay. So by now I think we have covered everything related to neurofibromatosis. So regarding the management, neurofibromatosis, by the way, usually it will not cause any problem. Usually, okay, but the management, okay, will depend on the complication. Okay, management and investigation will depend on the complication. For instance, if the patient has got back pain, we need to do imaging to know the cause. If he got high blood pressure, we need to know whether this is related to pheochromocytoma. Oh, so if there is symptoms, we will do urinary
or secondary epilepsy. Or secondary epilepsy.
Yes, epilepsy is also one of the complications. Yeah. Just a few minutes. Someone is trying to call me. Just a minute. Sorry for interruption. Okay, Dr. Tariq, it's very good that you mentioned epilepsy, okay, because this is another point we need to discuss. Just to mention the complication, there is risk of developing epilepsy, although it is rare, okay, and there is also risk of developing cancer, okay. Which type of cancer? Usually the plexiform neuroma we just mentioned, the one which is large, diffuse border, painful, sometimes itchy. Okay, usually this plexiform neuroma, the skin over it will be either a large coffee oil spot or red to purple in color. Sometimes there will be excess hair grows over this plexiform neuroma. Okay, this plexiform neuroma might develop cancer. Okay, might be complicated by cancer. The name of the cancer is malignant peripheral nerve sheath tumor. Malignant peripheral nerve sheath tumor. Okay, so you need to warn the patient in case you develop any abnormal pain. Okay, without trauma, continuous pain. Okay, in case you develop any tingling, numbness, weakness, you have to report to hospital for assessment, because this might be sign of malignant transformation of the plexiform neuroma. It is the only skin lesion which can change to malignancy. Okay, others are benign, harmless, never develop cancer. So complications in addition to the one we mentioned, I mean the back pain, the high blood pressure, the epilepsy, space occupying lesion. Okay, there is risk of malignant transformation for the plexiform neuroma. The name of the malignancy is malignant peripheral nerve sheath tumor. Okay, so back again for the investigation and management, it will depend on the complication. Usually neurofibromatosis patient will live normal life. Okay, sometimes it is not even regarded as a disease. Okay, and it will not shorten life, but the management and investigation will depend on the complication they develop. Did you get that?
Yes, doctor, but I suppose that there is no need for genetic testing for neurofibromatosis, right? Is that right?
This is a good point. Neurofibromatosis, the diagnosis is clinical only. No need to go for genetic testing unless there is no family history. You need to confirm new mutation in the patient. Okay, if there is no family history, okay, you can go for genetic testing. But usually the diagnosis is clinical according to the criteria we have just mentioned. Okay.
Yes.
So if the patient developed complication of back pain, we will do imaging to know the cause. Okay, whether it is imaging or DEXA scan to confirm osteoporosis, or to look for MRI to look for dural ectasia, X-ray to look for any osseous lesions. Okay, according to just to look for, to try and look for the cause of the back pain. Okay, vitamin D levels and calcium levels and so on. For pheochromocytoma, we will do a 24-hour catecholamine level to confirm pheochromocytoma, and if that was elevated, then we are going to do MRI for the abdomen, okay, or PET scan, okay, and sometimes they are doing a specific type of imaging to detect tumors in the adrenal. The name of imaging is methyl iodo benzyl guanine. Methyl iodo benzyl guanine. The abbreviation is MIBG. MIBG, yes, MIBG. Methyl iodo benzyl guanine. This is specific to detect any tumors in the adrenals. And if that was the case, adrenalectomy is the treatment. Okay, so this is for pheochromocytoma. For epilepsy, like normal, imaging for the brain to exclude any space occupying lesion, EEG, and so on. Okay, so investigation and management will depend on the complications, not on the disease per se. The clinical presentation, whether the lesion nodule, whether the neurofibromas or coffee oil spot, is just a matter of cosmetic treatment. Okay, either laser therapy or surgical excision, and this will be done with the dermatologists or plastic surgeons. Okay, so hope everything is clear so far.
Yes, thank you.
Okay, any question?
Doctor, for RAS, the renal artery stenosis, it's enough to put the patient on antihypertensive medication and optimize the lifestyle changes.
Yeah, we will start with this, but there is surgical treatment also. He will need to be referred for vascular surgeons. Yeah, not necessarily for surgery, but you will start with medical treatment and refer him for vascular surgery for assessment. Okay. So any other question? Today's session is going to be a little bit long. So I think if no question, we can move to the next case. Any other question, guys? Hope. By the way, neurofibromatosis keeps appear again and again in PACES. It's very common. Okay, and if you do not know the approach, you will lose a lot of marks in this station. Okay, because there is a lot of things to cover. Just make it as a rule. Whenever you enter Station 5 case, you have 4 C's plus Abbas driving. 4 C's plus Abbas driving. Clinical presentation, cause, complication, coincides, or association, if any. For instance, if the patient has got autoimmune disease, you have to search for the other association. In addition to these 4 C's, you have to cover Abbas driving in order to protect your neck about the clinical judgment. Okay, because if you do not tell the patient that I will admit you to hospital or I will refer you, it will be a problem. If you do not offer pain control or stop smoking or alcohol or driving, it will be a problem also. Someone asked in the chat about stopping driving. In this particular case, no need to stop driving so far, but in case that the patient has got optic glioma and a problem with his vision, at that time you can stop driving. Okay. So I will just share the scenario for Station 4 in the group.